Most of the times we see intraoperatively moving cataracts. Okay, this is NS4 cataract with phacodonosis. I started with phaco. It is moving extensively. I took CTR. CTR should be negotiated into posterior to capsular axis in a circular manner and in a horizontal manner. Otherwise, it may pierce the fornix of the capsular bag and will escape into the vitreous. I took 2 McPherson forceps and I am dialing trailing loop and completed the surgery and do cortical aspiration and implanting IOL. This is next case. This is a traumatic cataract with anterior capsular calcification. First I will check whether I go ahead with the phacoemulsification. If it is not possible, then only I put CTR. But inside checking but whether it is going behind rexis or not. This is on McPherson forceps. It is going smoothly. Otherwise, I take 2 McPherson forceps and stabilize one with one hand and negotiate with the other hand. And don't lose the trailing loop. Otherwise, it will be difficult to catch it again. This is one more case. How to play? It is not going, that's why I took help of dialer, engaging that leading loop. Now I am stabilizing with McPherson forceps and I am taking another one. But movement should be in a circular manner and horizontal manner. Otherwise, it will go posterior. To release it, I am taking help of another dialer. In this case, I kept CTR after completion of echo. This is little bit difficult. It may PSPC. Carefully we have to insert. Okay, thank you. Complications are postcapsular rupture, dislocation into vitreous, extension of dialysis. Sometimes removal of whole bag may happen. Thank you.
Thank you, Dr. Nasrin. Beautifully shown cataract surgery and CTR being implanted. Just for a clarification for the house, ma'am, what would be the indication for putting CTR before we do phaco? Or sometimes people like to fix the bag with, the fixation devices by hooks, complete the phaco, then put CTR subsequently. So what do you think the indication for putting CTR before we do phaco in these cases?
Whenever I am facing difficulty by proceeding with the surgery, I am putting with when nucleus is there, sir. It is easier.
Okay.
Once we remove nucleus, there is the risk of postcapsular rent.
Once you inflate the bag with a viscoelastic, then it goes, easily inside this thing. The idea is once you put a CTR beforehand, sometimes, the cortical aspiration or epicortical cushion becomes very difficult to remove. It holds the, cortex behind the CTR.
Sir, we are doing since 20 years.
So you may have to struggle sometimes, especially in a softer cataract, because sometimes CTR might block. Then you have to pull these, cortex little tangentially to pull it. If you pull it like this, it's going to pull the CTR also.
Sir.
So that is a little trick you like to know. And she brought out the, cases beautifully. And towards the end, she also gave a few points on a complication which can occur putting CTR, especially PC rupture, CTR opening into the sulcus, going backwards. So those things can be managed if you have a nice visible capsular excision margin, as she showed. Staining of capsule is very important to see CTR going right in the right direction. Beautiful surgery, ma'am. Thank you.